I'm going to talk to you about this recent paper in the New England that I was privileged to be involved in with many people from the 100,000 Genomes project. I just wanted to open by sharing with you that in the United Kingdom, we have a national genomic strategy, which is sponsored by the national government, your federal government equivalent. And on the left-hand side of this strategy, you can see over the next 10 years that the UK will focus on genomic testing in the health system, using the platform of the 100,000 Genomes project, but enlarging to a new genomic medicine service, undertaking 500,000 whole genomes against a standardized test directory over the next 10 years. Well, in fact, 500,000 will be over the next 5 years. We also have new cohorts, a bit like all of us in the United States. We have a 5 million cohort, which is now called Our Future Health. That's just starting up. And then we have assets that many of you worked on, United Kingdom Biobank, and also our NIHR Bioresource. So we move from a continuum of healthcare prevention and research, and we can move back and forth between those. And the idea is to create an ecosystem where we can rapidly translate the findings that you and I make in our research labs directly into the NHS. So the 100,000 Genomes project was a special project of the previous Prime Minister of the UK, David Cameron, and he decided that it would be whole genome sequencing, not exomes or other tests. And then 4 groups were assembled to advise on what areas we should look at, and they made the advice that we should focus on rare disease, cancer and infection, because those will be tractable to healthcare again. Mostly I'll focus today on rare disease, but also some other disorders, just to share with you where we are in our thinking, as well as covering the New England Journal paper. So we reached over 97,000 families who participated from the NHS, our free at point of care health system. And that's generated over 90,000 whole genomes, as you might imagine, and that's over 40 petabytes of data. We store that in a secure data center, which is migrating at the moment to the Amazon cloud. And we have created in the NHS an infrastructure. Initially, this was 13 genomic medicine centers that covered 98 hospital trusts. That's about half of the hospitals in England. So we've now changed that to be 7 genomic medicine service alliances, which are focused centers of excellence where the patients are, and they provide clinical care, and they're linked to lab hubs. And I'll show you the anatomy of the system we've created in a moment. But the reason we've concentrated down is to combine expertise, because you know only too well at Boston Children's, this is really not so easy to do. And we now reach across all 220 NHS hospitals in England. At the peak of the program, 5,000 frontline staff, and I expect, as I'm at Boston Children, this won't be a surprise to you, that if you want a durable legacy in a health system, you need to get involved the guys at the front line. And at one point or other during their working week, about 5,000 frontline NHS staff touched this project. They might be moving samples around, they might be taking consent, they might be doing genetic counseling. So what this creates is a durable champion group that when you come to look at whether you should place this inside the health system, you have these advocates who've invested a lot of time in it and they're very supportive. And also because this, at that time in 2013, was really essentially a research tool. There were very few people doing whole genomes in clinical care, except for a few cases, as many of you will know here. Outside of places like you have at the Broad, there was very little whole genome sequencing. And so what we did was we openly advertised twice in Nature, and over 3,000 researchers from 33 countries agreed to come and work on the data to drive up its value for healthcare so that we could adopt as much of this in direct care. So I'm going to take you through the New England Journal paper, which was led by my colleague and I, that's Damien Smedley, with many other authors, and I'll show you the authors at the end. But this is really a tribute to frontline healthcare professionals in our National Health Service. So when we started the project, we wanted to do a pilot. It's quite hard to describe this project when we, in the sense that when we were first commissioned to do this, the government decided that they wanted to create a dedicated entity to do this. So they formed a company called Genomics England, which is wholly owned by the Department of Health and Social Care, which means it's actually owned by the taxpayers, really. So it's like a public company. And the reason that they wanted to do that is they wanted to concentrate the endeavor around making this work in one single entity that they could call to account. So that's why Genomics England exists. And then also, they also wanted us to harness the best from across the world. So in August 2013, we visited the United States amongst other countries, and we realized that nobody had an end-to-end pipeline to do this, and that we would need to build things. So we were obviously already extant, and we began a pilot. And so this felt at that time like we were building an aircraft whilst we were trying to fly it, which is not necessarily what we like to do in healthcare. But the pilot allowed us to establish infrastructure, learn what didn't work, what did work, and to try and marshal the best possible outcomes for patients. One of the first things we did in the pilot was to standardize eligibility and phenotyping criteria. What we found was there were various different types of description of diseases, but sometimes clinical features that are associated with diseases were left out, or once a clinical diagnostician had seen a pattern, they would focus on the pattern and forget about the other clinical features because they didn't fit the pattern. So we asked them to record as many clinical data points as possible using the human phenotyping ontology, and that anchored it in a form of standardization that means I can talk to your data potentially at Boston Children's. We built automated analytics, although we found people who had built elements of an automated pipeline, they hadn't stuck it together. And there was no real accredited pipeline. So we set about accrediting. In the UK, we would use ISO. You would use other systems like CLIA in the United States. And then we got the NHS involved. And initially, we were looking at gene panels using Panel App, which we built during the pilot. Now we've moved on to more gene agnostic analysis and ranging genome wide. And in this program, we did range genome wide because you're not really using the whole genome if you're focused on exonic panels. And that doesn't seem to be a good use of this technology. So we actually enrolled these families from a network of 9 hospitals across England, and frontline clinicians did the enrollment. We extracted DNA and we sequenced it in partnership with Illumina. And we were also simultaneously testing Illumina against other technologies that existed. And at that time, you'll recall, Complete Genomics existed. We compared them in what we called a bake-off, which was really a scientific comparison. And what you find if you do that is, and this is true today as well, if you do BGI which have taken over Complete Genomics and Illumina, you will get an overlapping Venn diagram in which the overwhelming majority of variants, single nucleotide variants, are detected by both technologies. But actually, there are some things that each technology finds that the other doesn't, and they pass QC. What you're seeing here is a range of disorders that we worked on in the main program, and we covered nominated diseases by clinicians. In the pilot, clinicians also nominated diseases. The primary criteria was unmet diagnostic need. So we worked on 161 disorders, and I'll show you what they are in a moment. This is one of the early pilot cases here, and some of you may have seen me talk about this before. This child presented at about 4 months with some degree of intellectual delay, falling behind her milestones, and then developed intractable seizures, unresponsive to any anti-epileptic. And she'd already had exome sequencing and other genomic tests, and she was enrolled because nothing had been found. So with the whole genome, we found that she had a glucose transporter 1 mutation and had an epileptic encephalopathy. And this was a mutation that's next to a known mutation, but is close to the exon-intron boundary, and therefore had been passed over slightly by the, or hadn't got good quality exonic data in an exome. So this child then got a ketogenic diet, as you'll imagine, and that dramatically improved her seizures, and she showed some developmental improvement. She's a lot better than she was at that time, and still thriving today. The other thing about this was this turned out to be de novo in her. So her mum and dad don't have it, and therefore they have proceeded to attempt to have another child, which they weren't going to do. And I don't need to speak to this audience about the family-wide consequence of these resources. And also, I should emphasize, wherever possible, we attempt to enroll a parent-offspring trio, because as you all know here, this gives you better line of sight on a diagnosis. But here's the journey this young girl's genome went on in this program. So she had 6.4 million variants. That's slightly on the high side for number of variants in her genome. 677,000 were rare. 2,826 were predicted to change a protein. 67 were different from her mum and dad, and one was a clear-cut cause of her condition and was listed and had been observed before, although it was relatively new. So this is the journey that people's genomes in the project go, and we can get through these in parallel in a few hours, and we do multiple parallel analyses all the time. So I'll give you some cases from the pilot, some of which are in the paper and some of which I'll just highlight because they illustrate a concept. You'll probably be well familiar with these. This first one is a 4-month-old with fluctuating neurology, repeated infections, went straight to the NICU, never really left the NICU, and died with no diagnosis. Immune testing was negative, but the mum and dad wanted to enroll the child in the program because they wanted to understand what this would mean for future reproductive health. And then mum unexpectedly became pregnant. She said, look, I don't want to know the diagnosis, don't tell me. But at month 8, she became pretty anxious, and she said, actually, I really would quite like to know now. And we found a pathogenic transcobalamin 2 mutation, which explains the entire phenotype of the presenting child with fluctuating neurology, repeated infections. And his brother was born a few weeks later. This is 6 years ago now. And that boy tested positive, sadly. But because the NHS knew where to look, they could do a test within 1 week. And because of case reports, such as Journal of Pediatrics 1974, he was given high-dose vitamin B12 weekly, and that child is at a completely different outturn. Now, I want to just pause for a second to say that the multiple weeks spent in the NICU means that this child cost the health system 70,000 sterling. If you contrast that to the few £100 it costs for a whole genome and its analysis, all of a sudden this technology doesn't look so unaffordable in this setting. And so this is part of the basis for adoption in the health system. The second is a 10-year-old child who had repeated admissions to ITU, so many that she had cost the health system £357,000. This time she was admitted with life-threatening chickenpox. She had a CTP synthase 1 gene mutation. This affects B and T lymphocyte responses to both capsulated infection and viruses. And that prioritized her for a curative bone marrow transplant, which she got. The transplant cost £70,000 versus her multiple admissions of £357,000. What if we could have found this earlier? And of course, one of the most important things that you and I can do as clinicians, it provided the opportunity to focus testing in the siblings and they're not at risk, which have been a great source of worry in the family. And that's based on case reports previously observed. Now, this is another case. This is a 5-year-old, and I've included this specifically here because this is where a genome, I'm not going to say speaks to us, but where a genome changes the diagnosis. So this boy had unexplained anemia, developmental delay, short stature, and constipation. He'd actually been given a diagnosis of Diamond-Blackfan anemia, which you know well may have a limited lifespan and may have cancer risk. But because he had intellectual disability, and you can see a video of this child on our website, he actually had a panel ran that identified a mutation in the thyroid hormone receptor alpha, and as a result, he could receive high-dose thyroid hormone replacement. And that boy is dramatically changed. In fact, if you look at the video, you can begin to see the change being affected by the thyroid hormone. He'll never be entirely normal, but he can walk much better, he can talk much better, and he interacts much better as a result of discovering this. And that's here where the genome reprioritizes the diagnosis, which it does sometimes. And I thought I'd include this here. It's almost unnecessary, this, for this audience, because you live it every day. But you'll all be familiar, as I was. I wasn't, because I'm not a pediatrician and I don't test these disorders in children. I actually tended to work previously on complex traits. And so I was very struck by, firstly, several things. One is how incredibly relieved and positive someone is in receiving a diagnosis, even if your next words are to say, actually, there isn't a treatment, but it's because it unlocks uncertainty. It creates a climate in which they can see that you and I have some insight into the biology. Mums and dads, as you will have in your practices, they know that if you and I can't give them an answer for what the biological cause of their child's illness is, or adults, we're unlikely to be able to treat it. Now, this child, this is the words of a mother, and this child, she thought, had a degenerative neurological disorder, and she thought she would end in a wheelchair and not live for very long. She had uncontrollable epilepsy. In the time I'm talking to you, she would have had probably a couple of seizures. She became really locked in and unable to communicate. And once we diagnosed the GAMP deficiency, which is a treatable metabolic disorder, as you all know, she received a diet with appropriate amino acid replacement or replacement dietary elements. And the child is now different. She's learning, she's free of epilepsy, and light's back in her eye. What if we could have discovered this shortly after birth? And you see the mum's view. Now, this will be familiar to you. Of course, I'm not going to suggest to this audience that this is always the case, because it's in fact rarely the case that we're able to go from a diagnosis to a treatment. But I do feel that together as a community, nationally and internationally, we're approaching a point where there is a drive towards nucleic acid therapies and other options for these people in a way that when I started the 100,000 Genomes Project, there wasn't. So moving to the New England Journal paper, the pilot comprised 2,183 families, and we tried wherever possible to get trios, but we also accepted larger family structures. What you'll see here is the distribution between males and females. I just want to draw one or two things to your attention. There were not so many children in this program because, so you might notice an adult bias. That is because we prioritized unmet need. So of course, our clinical colleagues enrolled cases which they'd had for a long time with no diagnosis. So it's not that we have some strange pattern of rare disease in the UK, it's that people prioritize long-standing unmet diagnostic need. So the demographics do look slightly unusual, and people have pointed this out, including written to me after the paper's published. That's the explanation. It's very simple. It's what they could enroll in a limited time frame. If you go to the demographics of our main program, which contains another 36,000 families, then it would fit with your clinical practice because they enrolled large numbers of children and pediatric disorders are well represented. So just want to share with you this. It didn't make it into the paper. For some reason, New England Journal thought we wouldn't include this particular bit of the diagram, but it illustrates an important point. In the blue is what you and I could have found if we had looked at SMBs or indels in panels. And then the yellow, green, and orange is what we can find with the whole genome. And here, what you're seeing is the diagnostic yield across all diseases. We achieved a 25% diagnostic yield for any disease on average. What you see on the right-hand side here is that in 1,234 families that had a clear monogenic etiology, or were very likely to have, we were able to achieve a 36% diagnostic yield. Those with a more complex, but probably oligogenic etiology, we achieved about 11% diagnostic yield. And you can see a ramp up from singleton to duo to trio. This histogram is slightly misleading. We tried to explain this, but I'm not sure we managed to convey it, in as much as it's not the case that when you get to quads or larger family structures, suddenly the diagnoses tail off. This, of course, is inside these this histogram, these individual columns are hidden different diseases. So, you know, the family quads, when you look at them, these are more difficult diseases that we've happened to enroll 4 family members in, and the larger family structures are the same. So it's a slightly misleading histogram, but it's what we found. So that's what we show. But this fits with your and my prior perception of this, that the more complex the family structure, the better it is to have many people in the family. And in some cases, we saw a clear evidence that more distantly affected relatives contributed more strongly to a diagnosis. We used a program that had been built by the International Mouse Phenotyping Consortium with Peter Robinson and Damien Smedley, who's the lead author on this paper at the front end. And this is showing you sensitivity and specificity, or sensitivity and positive predictive values of different strategies, whether you use a disease panel only, you apply certain panels, and then whether you use like Exomiser to add value. And across the range, we found that Exomiser, which integrates phenotypic model data alongside human phenotypes, actually helped us considerably to prioritize findings. And now Genomics England in its NHS pipeline uses Exomiser routinely as part of the diagnostic analysis that it does. So these are the different disorders, and I've reproduced this this is direct from the paper figure on showing you the different disorders. I just wanted to be completely honest with you that, although we're describing sometimes quite reasonable diagnostic yields, some of these columns have small numbers in them. You won't be surprised necessarily by that, but sometimes when I present this in a more general audience, they're a bit surprised. And the other thing is that some of the disorders probably falsely haven't got diagnosis, not falsely because we got it wrong, but because they were really challenging disorders. And just at the moment, we don't know what to do with those. But you will see that well above 25% are hearing or ear disorders, metabolic disorders, intellectual disability, neurological, neurodevelopmental disorders, and ophthalmology. And there are also positive diagnoses in skeletal disease, endocrine disorders, ciliopathies, and cardiac disorders. So overall, and they could open across any system, and this was the first time it was as broad as this for the whole genome. We watched very closely the excellent work done by the Undiagnosed Diseases Network, and we've learned a lot from those prior studies. But this is exactly what we found, which is a median of 25%, 36% or so in monogenic disorders, about 11% in more complex etiologies. Now, we went back and looked at whether you'd had a prior test or not had a prior test. Now, I recognize this might seem a bit strange, but the reality is, if I give you a picture of a free at point of care service, is that when that service builds up in an area that's relatively rare, and there are different centers doing it, they may, for various financial reasons, have different tests available. So they mightn't, like you guys, be able to order a panel from the health insurer, because that just may not be fundable for them. So what we did was look at whether you had prior testing or no prior testing. Whether you had prior testing or no prior testing didn't really matter. You got about 30% uplift in diagnostic yield. And then if we look at chromosomal testing, targeted testing, NGS panels, bit of a cautionary note on whole exomes because there's very few people there. This reflected the NHS at that time where we didn't have that much whole exome sequencing. But you can see there's some reasonable suggestion that whatever you do, a whole genome is better than no prior testing or prior testing of any type. And that was an important finding. This was quite influential on the National Health Service adopting this. So I'm just showing you the tree from the program in the paper that's describing that, we had 25% positive reports from straightforward looking at the diagnosis based either on coding SNVs or indels and applied panels, and then additional work where we applied Exomiser manual review at the genomic medicine centers. And we also work with two companies, which will be well familiar to Congenica and Fabric. And it's fair to say that they did add diagnostic uplift from that. So that's the diagnostic pipeline. That's what you get when you do it in healthcare. Now, what we tried to do was to combine a research ecosystem with that. And what you're seeing here is the result of the research ecosystem. Now, here the gain is perhaps not as much as you might hope for, but we're starting out on the journey. And one of the barriers, which you'll be well familiar with as an audience, is that we get stuck at function. So if I show you what the outturn was and how much utility in the clinic you got, you'll see that there are a large number of potential diagnoses from, for example, gene burden testing, but we haven't been able to functionally characterize those yet. We're working through them, but as soon as you move to function, you slow down quite considerably. So I'm just going to share with you the diagnostic odyssey of the children in this program, which fits with the diagnostic odyssey of our main program. So the children spent a median of 75 months attending 68 hospital appointments prior to a diagnosis, unaffected relatives, from the same families attended a median of 18 appointments over 20 months from birth. And what you see is after diagnosis, over the succeeding 18 months, there's fewer focused clinical episodes, and they're more focused on actually, is there something we can do for this child? It's not about test after test after test, which is what it was for the previous period. And these people, as you know, use a lot of healthcare. So the affected participants use 183,273 episodes of care, and it costs £15,310 over about 7 years of life. So this is not an inconsiderable cost. And of course, as I've shared with you earlier, with a genome now at a few £100 this makes a whole genome look like reasonable value. If you're willing to pay £15,000 not to get a diagnosis, then that doesn't look like good value. And then, of course, some of these people do have other contact with the health system. These are the unaffected relatives. So their cost is not inconsiderable in itself, but it's much lower per participant. And that doesn't include family physician or disease treatment costs. So 25% of the diagnosis had an immediate clinical utility, and approximately 14% would not have been discovered by an alternative technology. So 0.2% the clinician said had no current benefit. The remainder had unknown utility, and you can see how that's changed things. 52 we could prioritize future reproductive choice. 13 got into a trial. 32 had dietary shift or vitamins. But then here's the gene burden testing. We had 829 genome-wide significant signals, 249 unknown genes, and we'd already discovered those by other routes. And 579 were potential diagnoses, of which 22 we've now resolved, or the literature has resolved it for you. And you can see there, that's UBAP1 with hereditary spastic paraplegia, FOXJ1 in non-CF bronchiectasis, and SORD in Charcot-Marie Tooth, which are now known. So this is the barrier that we all face, which is converting gene burden tests into clear diagnosis for our patients. But we're pretty sure that there's buried treasure in those 529. So we then looked at the entirety of what the cost was of this program, including adults, and it turns out that they had spent £138 million over their lifetimes. Now, some of these people in this program had waited 30 years to get a diagnosis. So this is not inconsiderable cost. And this is how this could be affordable, because an earlier diagnosis can reprioritize the healthcare system. Here's something that wasn't in the New England Journal paper, but I want to share with you because it will be published around the 18th of this month in Lancet Neurology. So we've been working with Illumina and a centre in Cambridge on a program called Expansion Hunter, which you may be familiar with, which was thought unlikely to work initially because this is a short read technology, and you were reading across most of the length of the short read. But we've been able to use this technology to reconstruct, using all of our data, the normal distribution in the blue histogram on the left-hand side of repeats at known repeat expansion disorder loci. So you'll be familiar as an audience that these are 1 in 3,000 people. This is these are the commonest group of neurological inherited diseases. And you can see dramatic repeat expansions in shaded triangles, which was where they're to the right of the serrated line that you see here. So I'll draw your attention to one of those diagnoses. So if you go down to HTT, which is Huntington's, as you may have guessed, the others are hereditary ataxias and known ataxin genes, you'll see a dramatically expanded repeat, which was inherited from a father. This is a child that's was below at diagnosis, his 10th birthday, had been enrolled with unusual neurology. As you know, Huntington's in childhood sometimes has an atypical presentation. This child had quite dramatic neurology, but his dad was unaffected. So the clinicians had not suspected Huntington's. There was no known family history. And his father, who was well at the time, is right over near the serrated line, but has started to develop features of Huntington's disease a couple of years later. So at that time, this diagnosis might pave the way for an antisense oligonucleotide therapy or other therapies that we may generate for this, but this is quite a dramatic result for a family. And as a result, we've been able to validate these findings against over 400 PCR tests covering the range of known repeat expansion disorders. And as such, Expansion Hunter is now a component of our pipeline, and we run it on everybody. And we find it very useful in neurological disorders because it periodically shows you a repeat expansion disorder where you would not necessarily have immediately suspected that. And it produces pictures like this, which allow you to see that where your repeat is without doing lots and lots of individual PCR tests for the expansion. I'm just going to share with you a couple of other things we've been up to. In pharmacogenomics, we've been looking at the number of known pharmacogenes. So there's an international consortium, the Consortium of Pharmacogenetics in International Consortium, CPIC, and they have defined a number of gene-drug pairs. And we looked across the most common gene-drug pairs, about 18 of those. And what we can see is it doesn't matter what ancestry you look in, 99.5% of us possess at least one pharmacogene. In other words, if we come across the therapy, it will either be ineffective or we will suffer harm. And 25.4% of us have haplotypes in at least 4 PGX genes. Again, doesn't really matter what ancestry you are. So we're looking at bringing pharmacogenomic testing live as part of our national test directory. This will initially, as you might imagine, for affordability, be response mode. And then we're going to look at preemptive reporting on whole genomes that we do where it's appropriate and relevant. We're just working that up right now. So you're all invited to come and work on these data. We'd love you to do it if you're not already. You can come. At the moment, it's not charged. It may have to be charged in the future, but that will be on a cost recovery basis for the compute. So we invited people, and 3,580 from 33 countries, 413 institutions. But over 3,000 have completed and have had some access to the data, about 500 or so access to data every month. And they've independently won, which they keep, 50 million in grants. And we also work with some companies, and you can see in the blue where the people are. We'd like to see more people from the central grey areas involved. Hopefully they will come forward as time progresses, and we get those countries more involved in these programs. Just a little bit that we've been doing on UK Biobank. So we use the Genomics England data asset to look and compare to TopMed to see what difference and similarities there were. So there's 107 million of our variants that overlap directly with TopMed, and some of those overlap with the 34.8 million in the haplotype reference consortium. And then there are 148 million distinctive variants in TopMed, reflective of the different ancestries that have been included. And although we also have different ancestries, we've a smaller percentage of those in the Genomics England resource, and we've got 199 million different variants. And we've used this to re-impute Biobank because it's on the same ancestry specific genome. So what have we done with all this information, including the New England Journal paper? Well, we've used this to create a new national genomic medicine service. And one of the things I was really determined to do is that we would not leave the what you'd call a zip code lottery in place at the end of this project. We hadn't marched all these people to the top of the hill, done all this whole genome sequencing to say, now there you are, you sort the rest of it out. So we worked with the NHS to create genomic lab hubs initially. Genomic lab hubs in our system do all testing bar whole genomes. Whole genomes are still done by Genomics England in partnership with Illumina, and we have 500,000 for NHS service over the next 5 years. There's a commitment, absolute commitment, and they funded 300,000. They've done about 5,000 in the NHS, and it is finding diagnosis they wouldn't have found by other orthogonal approaches. And then we have 7 genomic medicine service alliances, which map precisely onto the lab hubs. So I'm very keen on this. Never connect the clinic from the lab. If you do that, people start losing clinical context or losing understanding of what testing is available. So we fully connected those, they're fully linked. And we also have a workforce development program trying to expand because we have an undercapacity of ICADA, genomic counselors, and other things that we need to bring this live in a health system. So this offers a new national test directory. We reviewed 300,000 tests. The data you've seen and is in the New England Journal paper paved the way for about 28 indications for rare diseases, which you go straight to whole genome. You do not do another test, you go straight to whole genome. The test directory is there, it's free to all, it's on the web. You can see how we developed it, and there is a national panel of independent experts that reviews the evidence as we generate it. What we did have to do, and I was particularly keen on this, is sometimes in the health system in the UK, we have overly rigorous criteria for accepting something as a test that we will use. This limits opportunity for individuals. It's really important to not allow that in rare disease to get in the way. And that requires us as a community to explain, well, you know, we've got the 6 cases who've got this variant. That's probably as good as it gets, because these are very rare cases. And, you know, actually, guess what? We had to assemble a lot of the world's literature to do this. And so that's not so easy for healthcare commissioners who may be deciding to fund a service to understand or accept, but we've managed to do it in the UK. And so we are now adopting whole genomes for certain disorders, ultra rare unidentified disorders where, you know, de novo mutations might be prominent. So this is the anatomy of the service, just to summarize it. So it's now more than 21, it's 28 in the latest release, which was in December 2021. The other thing we built in, which is important, is this field is very dynamic, and you're contributors at Boston Children's to the dynamism of that. And we really are grateful to you for all the work you do, not just to care for the patients at Boston Children, but also to contribute to the global endeavor in this area. And that's why we built in an annual test directory review. So normally in the health system in the UK, you may not be familiar with this, we normally fix what we do for 3 to 5 years. And I argued very strongly that that would leave us way behind, and we shouldn't allow that to happen. Importantly, everybody who we do whole genomes on, and other testing will also be offered this eventually, are offered consent for research. And where they're offered consent for research, just as we've done in the 100,000 Genomes project, we will follow them with every piece of health data electronically for their entire life course, including after their death, to understand why they died. And this will allow us as a community to build up a more comprehensive picture of what happens to these people, both before, during, and after diagnosis. It also has another virtue. It allows you and I to have a platform for recall for research, so that if there is a trial, as there sometimes are these days, we can engage people in those trials. And also we open it up to international researchers and industry. I'm going to finish with a couple of bits that you won't have seen. So this paper's in final review at Nature. I think they'll accept it, but who knows? This is COVID, severe COVID. So what we did in March 2020 was to ask the question, if we applied whole genomes to severely ill COVID-19 patients from intensive care units, could we find genomic findings, and would they possibly pave the way for therapies? And so we've looked so far at 7,491 severely ill cases from 224 UK ITUs, compare them to 48,000 unrelated controls, and then use the Host Genetics Initiative, which is a partnership across the world, particularly led from the Broad in Boston and also from Finland, FinGen. And we looked at those as a replication resource, and that's allowed us to find 23 genome-wide significant signals, of which 16 are novel and 1 or 2 are rare. I'll just share with you, this is the Manhattan plot, so you can see HLA there. You can also see what is a relatively rare variant in IFNAR10, which we couldn't have replicated because it's not present on genotyping chips in the Host Genetics Initiative, but Regeneron came to our rescue with exomes, and thankfully it was on the exome. We do also see some transancestry specificity, and these are the 3 loci that look promising in transancestry analysis, mostly driven by South Indian Asians. And we also see altered fold expression in transcriptomics in a TWAS, and here you can see the different genes which segregate around inflammation, immunity, and to some degree clotting and ABO blood groups. So we are finalizing a genomic analysis in children program, which I chaired a task and finish group, which involved colleagues from Boston, particularly Robert Green, and others from the United States, David Dimmock and David Bick, who advised us around early life use of whole genomes in intensive care and newborn screening. What we've stood up at the moment is a rapid exome service, and this is because turnaround on genomes is very expensive if you only sequence a child and 2 family members. But this service is live in the NHS, and it's a 37% or 39% diagnostic yield. And there are many diagnoses that have paved the way for treatment, particularly bone marrow transplants for immunodeficiency and other dietary shifts as well. And these were all patients from the NICU or PICU. So we looked at this in terms of a new program of newborn screening with a whole genome. And here we consider that the genome sequence was an assay, a measurement. The analysis could be taken at different points in life, could be context specific, and the results were the output, and they could be returned to the patient. But we would have to be careful of that. And so following ethical and societal advice, and we've consulted now with the public, we were looking at the use of whole genomes, and Genomics England has now been funded by the United Kingdom government to develop a newborn cohort over the next 3 years to explore early life newborn sequencing after birth. And this is focused on fully penetrant treatable disorders, as you might expect, in the first 5 years of life. And that means test detection, early diagnosis and intervention. And we want to focus on disorders where there will be clear benefit, but follow up people so we can also be able to recall people for research opportunities. So we developed something called RX Genes, which we published in the American College of Medical Genetics. And what that is a single source with an app that you can download to your phone, which tells you about treatable genomic disorders. So if that's of utility, it's there for you free. Tell us if we've got anything wrong. We're open to hearing that it's not quite right. And as a community, we can crowdsource good solutions to this. And some of these are simple treatments, dietary, vitamins, some of them more expensive transplants. Here's a screenshot of phenylketonuria, an obvious one. But you can look at that for yourself. And what we did find is that there are about 681 disease entities resulting from 665 genes, and some are more than one disease in one gene. And these disorders we're proposing only to feed back if they are relevant in the child in the first 5 years of life. So we're not at the moment feeding back on adult disorders as you would expect. So what we found is that if we look at this in real detail, we get to 639 disorders. That's about a frequency of 1 in 190 live births, where we can estimate the frequency. That'd be of 712,000 children born in 2019, which was our last year of normality, really. 10 children are born every day that would have a treatable disorder. If I take you to the US, 3.75 million births in 2019, that's 54 children born every day. And we're doing a pilot of various birth cohorts to estimate the false positive rate. As you'd expect, we don't want to be giving false positives back. We did some health economics work on this. And depending on the disorder that you look at, there's quite a wide range of funds that could be released if you got this early life diagnosis and were able to intervene before disability had onset. And obviously, because these are children, the quality adjusted life years gains are quite substantial. And incremental cost effectiveness ratios for this type of rare disease could be considered by some to be cost effective, but not all. So we've consulted with the public, and they said that they were very supportive of this. In green, that's what they said. In blue, they said they wanted it to be representative across a range of settings, not centers of excellence, test the evidence for whole genomes, and communicate that in a transparent way. But the public were very enthusiastic. We're now working with health professionals to help shape the program, and we will consult before, during, and after the program. And we're also looking to team up with US-based programs, such as those run by Robert Green, but there's also other US people who have been involved in this. And this has recently been a focus of an NIH gene therapy workshop. So GEL's future programs are diversity, genomics, cancer, and newborns. We'll continue to work on rare disease, as you've seen, and continue to publish updates on our findings. And so we now have a National Genomic Medicine Service providing consistent and equitable care for 56 million people. We didn't have that before. Standardized genomic consent is offered, particularly in whole genomes. Tests are from a national test directory. We're building a single UK genomic knowledge base, and this will be available to researchers and de-identified from industry and academia. For the future, and this is why I'm here, is a global coalition of intellects, and we want the UK to be at the heart of that, but we love working with you in Boston and elsewhere. These are the most important people in the program, not me. And I'm going to have to just say gently, not you either. These are the participants, and these are the people, and they want you to work on their genomes. And some of them have not yet get diagnosis, but they continue to be enthusiastic because they live in the hope that people like you will turn up and help us make those diagnoses, and maybe, just maybe, and often not, pave the way for a therapy or a therapeutic innovation. These are the people who made this paper possible. There's many of them, so I'm going to be rather quick on this because we're sort of out of time. But I thank every one of them, and they come from all across the UK, and some are international colleagues who helped us with various parts. And I'd like to thank all the funders, particularly Department of Health and Social Care, NHS England, and the patients who contributed to the programme. These are the authors on the potential Nature paper. It's not accepted yet. And you can see the funders of that study there. So I'd like to stop there, take any questions if there's time. Here's how to get in touch. Please do if you'd like to know more. Thanks so much.
Thank you so much, Mark. That was amazing, how much ground you have covered, and we're really very fortunate to hear you. Maybe open up for discussion.
Yeah, I'm sorry I was late joining, guys. I just couldn't break through the security. Sorry about that.
Not a problem.
Yep. If people want to ask questions, you can raise your hand and we'll unmute you to ask, or you can put it in a chat if you want to.
Yeah, while we are waiting I have a quick question. What do you see the future for 100,000 genome project? Are you gonna keep doing as you cross these numbers, or
yeah? So Pankaj, what we're doing is, so we've got the National Genomic Medicine Service. We're doing that sequencing. I'll admit to everybody here that today you can't justify whole genomes for everyone. There are perfectly good orthogonal tests that can be well used to diagnose certain situations, as you do every day. However, as time goes on, as you begin to see, and this is why I strayed off the New England Journal, if we can liberate other things that might affect the life course, and if you knew of them, you could take avoiding action. And you'll notice I steered well clear of polygenic risk scores because I think they're still a work in progress and they need to be proven. But I do think that if we could avoid harm with drugs or medicines, or we could use genomes early in an infectious disease pandemic like this one, and maybe tailor therapy, then we would be in a good place. And we will get the length of time to deliver a whole genome down. So I can see it broadening. I think the job isn't far from done in rare disease. I think function is a real barrier, which we're going to have a concerted effort on, because we really get stuck there. And that's not so easy to deal with at scale. It slows you down, but it's a battleground we have to tackle, because that's the barrier for full realization of this. I also think technologies are improving all the time. So for example, long read genomes, these will probably help us with some of these structural things that we're not seeing with short read genomes. So as the fidelity of those technologies, PacBio, ONT, and others, we may put them alongside a short read genome. And in the Genomic Medicine Service, we're beginning to look at those things as sort of pilot research projects alongside for unmet diagnostic need. The other thing we're doing, Pankaj, is to put transcriptomes alongside our undiagnosed people, because there's evidence from your neck of the woods and elsewhere that a transcriptome can unlock a diagnosis. We're also looking at high abundance, low abundance proteins. I don't know how that will shape, but we've decided to look at that. So I think the future probably, Pankaj, is a multi-omic approach, at least until we've unlocked some of these diagnoses that are hidden away. And then in cancer, it's also, I mean, 25%, I didn't show cancer data today, but 25% of the cancer participants got some sort of benefit that they could have a therapy or something. So it's not a hopeless result. And the other area we worked on was pathogens. And I think pathogens have proven themselves in COVID-19, that sequencing is pretty helpful. And so I think, pathogens will be another area. Other agencies have emerged that will take on the pathogens. We'll focus on the human. And the next phase is to test in a research program the value of this in newborns and optimize it further in cancer and get the diagnoses we haven't got in rare disease. So the rather long-winded answer, I'm sorry.
No, that's great. Thank you so much for describing the vision. That's great. Thank you. You have any questions, anyone else?
I had two sort of unrelated questions. One, I think you alluded to a bit, but more specifically looking at the unsolved cases or non-diagnosed, are there plans or is there a system set up to sort of trigger automatic reanalysis on maybe an annual basis or less, just looking at new genes? And
so, Courtney, this is quite an current area. You've hit the nail on the head. Some folks say that we should be reanalyzing these every few months because of new knowledge. So we have done some limited reanalysis, and we can certainly see a diagnostic uplift. This is a combination of new knowledge, better analytics, and more functional data available. So I actually think you're absolutely right that we should reanalyze these genomes. We're talking about at least annually, and they're just about to do the first. So we haven't done it annually before, but we're just about to revisit the first lot, and I think that may be underway. We also have a limited list. I didn't talk about this, that we fed back in the main program, which we fed back of additional findings. So out of about 97,000 people, about 1,000 will likely have some form of finding in their germline genome, which could help them across fully penetrant disorders. So when we thought about this, we were starting right in the period when the ACMG list of 56 had come out. And there was quite a bit of debate in the community about this. So we decided to avoid variably penetrant disorders at that time, because we tested it with our professional community. And there were quite a lot of the community who said, if you do this on fully penetrant disorders, then I'll be willing to travel with you on this journey. But in the health system, I'm not willing to tell people that they might have a hereditary disorder of rhythm when you've got a very variably penetrant variant. I'm just not willing to do that. I mean, if there's no family history, I'm just very wary of that. So we took a middle ground to bring the community with us, and that's just concluding now, and the results of that will eventually be published. But I do think, to your point, reanalysis at least annually is mandatory. That's my view, although we haven't done it. But I just think, you can't look these people in the eye and say, look, we did the test, it didn't show anything. When we know that actually locked away in a data center, we've got their whole genome. And analytics are changing the whole time. Our knowledge is changing the whole time. And other people around the world are solving some of these diseases. So we think that you'll get, from reanalysis we've done, we think you get about another 6% uplift in diagnosis just from new knowledge, improved analytics. So it is worth it.
That's great. And I suppose it sounds like you have the system in place that it's not too much of a workload to reanalyze everything every year once you've got the automated filtering and everything down.
Well, that's partly true, but Courtney, one of the things that people tend to do when they build systems is to build systems that look for duplicates and exclude them because they worry about duplicates. Actually, that's pretty unhelpful if you've already analyzed a genome. So we've had to do some patching up of the systems to put things through a second time. And I mean, I did say we would reanalyze genomes at the outset, but when people build out these programs, they do look for duplicates because, they don't want a duplicate to appear in the system and for people not to recognize that's a duplicate. This is a way, in their minds, this was a way to get spurious diagnoses. And I can see the logic, but I also want to be able to put them through again. So we've adjusted the systems to do that now.